respected Anju ma'am, Anita madam, all dear colleagues. Actually, today what I am going to present is amnioinfusion for prolongation of pregnancy in cases of severe oligoamniosis. As well as in the end, I will explain you if those who are interested to go for amnioinfusion in full-term pregnancy and oligoamniosis. So, I have started doing amnioinfusion. My first amnioinfusion I have done in 1997. Actually, I was very keen to do it in my postgraduate days when my HOD told any patient who is having severe oligoamniosis at around 20 weeks, 22 weeks, अभी तो कुछ नहीं होगा बहन, ये तो बच्चा कुछ नहीं कर सकते, पानी नहीं है, दब के मर जाएगा. And at that time I always asked my HOD that, madam, can't we do something, can't we do infuse fluid in the uterus just to prevent the death or cord compression in these babies? And she every time said me no. And whenever such type of patient came, I always go and ask my madam, can we do this? Till the end I was not given permission, but after I come here in Valsad, I was little bit worried because I was very new and beginner. At the same time, what you all are having, the kripa of Google Baba, yeah? नहीं मालूम है, चलो गूगल बाबा को पूछ लेते हैं. But we didn't have those facilities during those days. But at the same time, we have so many journals and so many articles. Everything I have searched, but nothing was given in that for amnioinfusion. So I was worried, should I start doing this in my private practice in beginning? But one day I had one patient who is having twin pregnancy. One sac is totally dry, and one is having normal amniotic fluid. And during labor, what I have seen, that in dry sac, the baby started having distress because of cord compression. So I told them to go for cesarean section, but that patient was not at all willing. Even the relatives were not at all willing. Then I thought at least I should give trial for doing amnioinfusion in such a case, because that baby was going to die definitely, because the distress happened in very early stage of labor. So I explained the relative and I did amnioinfusion under ultrasound guidance, and by the grace of God, the fetal heart rate became normal because we infused fluid in that, and the baby, both baby delivered having normal Afghan score. So then I started some confidence to do this, and at the end I realized, I have come to know that the patient who said no for cesarean section, she had previous 2 female child, and in these twins they have done SD, and both these child were also female. So they were not ready for cesarean section. एक जाए तो ठीक है, चार बेटी का क्या करेंगे like that. But I think all four babies now are happy, healthy, and parents are also now happy and healthy. So now we'll start. Here I am first going to tell you about the amnioinfusion to prolong the pregnancy. Patients who are having severe oligoamniosis in either early second trimester or late second trimester or early third trimester. So, prolongation of pregnancy in cases of severe oligoamniosis, all the cases what I have taken were the amniotic fluid index were less than 5 centimeter in mid second trimester or early third trimester by amnioinfusion and achieve good perinatal outcome without any major maternal or fetal complication. So now let us just brush up our memories or knowledge for oligoamniosis. So when the amniotic fluid volume is less than or equal to 5th percentile for that particular gestational age, then it is called oligoamniosis. Okay, the amniotic fluid, when we started measuring amniotic fluid, when the uterus goes above the umbilical level, at that time when the amniotic fluid index is less or equal to 5 centimeter, then it is oligoamniosis. And when the single largest vertical pocket, remember it is vertical pocket. Many a time if you keep your transducer, abdominal transducer oblique, then it is wrong. Then the report is wrong. So always try to make it vertical. So when a single largest vertical pocket less or equal to 2 centimeter, then it is oligoamniosis. So amniotic fluid volume differs from beginning to end. So initially at 8 weeks amniotic fluid increase 10 ml per week, but at 13 weeks amniotic fluid increase 25 ml per week, and then at 21 weeks amniotic fluid increases up to 60 ml per week, and then around 30 to 33 weeks it reaches to its peak. In first half, amniotic fluid volume is closely correlates with the fetal weight. So, etiology. Many a time we see the etiology, commonest cause is idiopathic. And for idiopathic, we are just sacrificing the fetuses. There is no reason, no fetal anomaly, no maternal cause, and we are sacrificing the fetus. It is not good. In maternal cases, PIH, chronic hypertension, antiphospholipid antibody syndrome, uncontrolled diabetes mellitus causes oligoamniosis. Whenever there is chronic abruption, many a time what we see in first trimester, we are having a patient with recurrent bleeding PV, and what we see is a slight separation of placenta or chorionic separation, what the sonologist write in the report. So I always ask them, please write down the circumference, how much abruption is there or separation. If it is more than half, then this patient is going to develop oligoamniosis as well as IUGR in further pregnancy. So just writing that chorionic separation is not enough. So always ask your sonologist about that. Okay, how much separation of chorion is there? Okay. And premature rupture of membrane. That is the commonest cause for oligoamniosis. In fetal anomalies, there are some chromosomal anomalies and mainly bilateral polycystic kidney or agenesis of kidney. Remember one thing, if patient develop oligoamniosis early in the 7th trimester, means around 20 weeks or less than 24 weeks, then there are more chances of agenesis of kidney or fetal kidney problem. Rest other cases, oligoamniosis develop later on. Okay? And in postpartum pregnancy, IUGR and in PUV, that is posterior urethral valve in male baby. These all will cause oligoamniosis. And drugs like prostaglandin synthase inhibitors and ACE inhibitors are causing oligoamniosis. I have seen so many doctors who are prescribing tranexamic acid and mefenamic acid, meftal for pain during pregnancy. And patient feels that okay, this is a painkiller and doctor has prescribed, so I will continue this whenever it is needed. And without your knowledge, they will continue. So please don't write NSAID as a analgesic during pregnancy. It is contraindicated, and if patient continues those NSAID during pregnancy, it will lead to oligoamniosis. In all these cases, I had one patient who came from outside, was on mefenamic acid at least on alternate day. So, what are the complications of oligoamniosis? Why should we go for amnioinfusion? So, for fetal problem, because of less liquor, there are chances of cord compression, intrauterine fetal death, intrauterine growth retardation, and this amniotic fluid fetus swallow and urinate. Okay, so during this it goes also into the lungs, so it is helpful for developing the lungs. So if amniotic fluid is very less from late 2nd trimester, remember, then this baby will not develop the lungs. This fetus have lung hypoplasia, and after delivery, even whatever you do, positive pressure, ventilation and everything, the oxygen will not go up and the baby will die within 1 hour. Because of this compression and no liquor, it causes limb deformities and sometimes limb amputation because of forming band syndrome in these fetuses. And because of this less liquor, there are high chances of distress in this baby, and this leads to meconium aspiration syndrome. Liquor is less and chances of fetal distress are high. Both these problem causes meconium and thick meconium, and at the time of delivery the baby will have low of guard. So these are the fetal complication of oligoamniosis. And in maternal complication, what we can see is because of less liquor, the total force which the amniotic fluid caused during labor is lacking. So there is prolonged labor, delay in cervical dilatation, and higher chances of operative deliveries in this patient. So these are just the amniotic fluid volume, what is normal, what is abnormal, and here what you can see at 34 weeks, 11.7 fifth percentile, and this is 95th percentile is polyhydramnios. So these are the different ranges of amniotic fluid volume at different gestational weeks. And here you can see easily. This is the normal graph. This is a centimeter A5 in centimeter. This is the 5th percentile. Below this all are oligoamniosis, and above this all are polyhydramnios. So in my study, the selection criteria, that was also done by me only, because nothing was there in any literature at that time. So what we have seen and what we have selected is inclusion criteria and exclusion criteria. In inclusion criteria, all the patients we selected having less or equal to 5 centimeter of amniotic fluid index, and remember one thing, normal umbilical artery blood flow on color Doppler. If there is absent color flow or reversal, then there is no use of doing amnioinfusion, only because baby is not getting blood flow properly, and at that time this baby is going to die in utero anyway, even after amnioinfusion. So this is the inclusion criteria, and in exclusion criteria, fetal anomaly incompatible with life. Because I have done amnioinfusion in one fetus having PUV, posterior urethral valve with bilateral enlarged kidney. Okay, at that time we need to do a regular follow-up of the cortical thickness of the fetal kidney and then deliver accordingly, but do the amnioinfusion simultaneously. Previous scar on the uterus, leaking PV. Leaking PV, there is no use of doing amnioinfusion. ऊपर से डालो नीचे से निकलेगा, ऊपर से डालो नीचे से निकलेगा. No use. And patient, I told you that one patient was on NSAID, and as soon as I stopped that and given her hydration therapy, and she developed normal fluid. So these are the exclusion criteria. And what should be done for these cases? So important thing is always explain the patient as well as relative about the exact procedure. My most of the cases what I have included here, I think 11 patients were from outside, from Surat, Vapi and Valsad. They have referred their patient to me for amnioinfusion. And I think 6 patients were my own patients. So first, explain the patient about the problem. Second, explain about the procedure exactly. Third, take the written consent about the procedure as well as chances of preterm delivery. Because anything that you do distant the uterus, there are chances of preterm delivery, but we give topologies to this patient. So till date, I didn't have any patient who delivered prematurely because of amnioinfusion, but it is always better to take consent. Third thing, I always take consent that if I am infusing this fluid, it will remain in utero for maybe for 10 days, maybe for 5 days, don't know. And we may need repeat infusion also. So that should be explained and should be taken in written. And most important thing is chromosomal abnormality. Most of these patients are coming at around 26-28 weeks to me. So at that time I cannot send NIPT or any other things because that is very expensive and they are not doing nowadays. So after 28 weeks they won't do NIPT to rule out chromosomal abnormality. So we need to take written consent that if we don't know about any chromosomal abnormality that this baby is having. Okay? So these 3 types of consent were taken before this procedure. And we do it under total aseptic precaution, give local anesthesia. First we see exactly the pocket where we want to introduce the saline, okay, and then give do the bending, wrapping, everything, give local anesthesia, and do prick with the number 11 knife because we are introducing epidural needle, and this epidural needle is blunt. So after that, introduce the epidural needle, number 18 gauge, and then aspirate it, see the needle is in proper place or not, intraamniotic or not, and then start infusing either normal saline or ringer lactate. And how much we need to infuse? Again, it depends upon how dry is the cavity. Because many a time we have seen there is zero liquor. They need something more. Okay, if patient is having 5 centimeter AFI, but there are some pocket here there also with cord, then also it is we need less fluid. So during infusion, the infusion rate initially is 30 drops per minute, then we increase it by 80 to 90 drops per minute. And before procedure, we definitely do give the intrauterine hydrochloride intramuscularly at least half an hour, ideally 1 hour before the procedure, and prophylactic antibiotic coverage. One important thing that we observe is it is written that it should be the temperature of the fluid what we are introducing should have normal room temperature. But in winter season, it is very cold here. So it happened to us. We directly infuse in one patient, and then suddenly that baby started developing severe bradycardia. So then we realized that the saline was very cold. So in winter, always we immerse the pint in hot water for 5 minutes, and then we do infusion. This is also a nice case. My first amnioinfusion for prolongation of pregnancy, what I did was in 1998, and that patient was having bad obstetric history. She had previous 3 missed abortions, 1 female child healthy, then 3 missed abortion, and then she came to me at around 22 weeks directly with severe hypertension and zero liquor. At that time, I explained her that if I don't do anything, then this baby is going to die in utero. I don't know whether I can help fully or not, but we can try by doing amnioinfusion at this time. She had hypertension, but she was not knowing that it was chronic, it was there before pregnancy or not, because she came to me at 22 weeks. So I explained her and did amnioinfusion, and at the time of amnioinfusion there was little bit meconium also at that time during I aspirated. And then after infusion, by the grace of God, what I have seen is we controlled her hypertension. We did so much lifestyle modification, meditation, everything, and after controlling her hypertension, we have not done any amnioinfusion thereafter. And this baby was delivered at around 36 weeks, 34 to 36 weeks, because of severe IUGR, because of her hypertension and bad obstetric history. So, and that baby is now just living in the next society. That male baby is doing very well, and mother is very happy. So we are following these cases. After doing amnioinfusion, they are healthy and their milestones are very nice. See, here you can see this is the epidural needle, and here you can see this needle. Can you see this? And this pocket is increasing. We always see during infusion that it is in proper place or not. And how to select the pocket and everything I have explained in next slide. Here you can see the difficult cases are these where placenta is anterior. Then it will be very difficult for us because we cannot go through placenta. Second thing, there is no pocket at all in these cases. They are a little bit difficult for us. Now, site of infusion. So we preferably do the infusion in the gap between the upper and lower limb. That is the safest area. But we cannot get it every time. We don't infuse through the lateral side of lower segment. Why? Because there are uterine vessels and we are using number 18 gauge epidural needle. So it may cause intra-abdominal bleeding. So we are avoiding that place. In obese patient, usually we pass through the umbilicus. We don't pass through the placenta. The patient's position may be changed to get the proper accessible pocket. Sometimes we say कि patient ने जरा laterally सूडावीए तो थोड़ું pocket મળે, थोड़ું head up करावीए, कई કરીને थोड़ा adjust करिए, but it is very tight. Now, what is the management for these all the cases? So, repeat the sonography for amount of liver and for the fetal growth twice weekly for 4 weeks and then once weekly. So just we have idea in this patient the fluid what we infuse will remain for how long. Okay? And we keep the DFMC chart, we treat the main cause, hypertension, diabetes, anything there. We start low dose aspirin, glucocorticoid for fetal lung maturity were given as needed. Regular ANC and medications were definitely given. Extra things what we always explain to the patient is balanced diet, hydration therapy and lifestyle modification. हमेशा पेशेंट ने એવું કહીએ टाइम से खाना है, टाइम से सोना है, रोज एक्सरसाइज करना है एंड डू प्राणायाम, मोस्ट कॉमनली अनुलोम विलोम. That is very helpful to increase the oxygenation. Even you can also do, keep SpO2 on your hand and then tell that patient do anulom vilom, and then you can see that there is definitely improvement in the oxygenation. So these are the patients and age distribution of the patient. There are 17 patients in whom I did amnioinfusion for prolongation. These are the socio-economical groups. Many times we think that around majority were from lower classes, but it was not like that. In my study, majority of them were from middle classes. Gestational age at first infusion. So I had 2 patients in whom I did amnioinfusion in early second trimester. Rest were late second trimester or early third trimester. These are the number of amnioinfusion. What I said, only in 1 year, 1 infusion, 2 infusion, 3 infusion and 4 infusions. Okay? So in 4 patients I need only 1 infusions, but in rest 2, 3 or 4. And probable cause for oligoamniosis, it may be bad obstetric history, PIH, stress, idiopathic. And then in idiopathic, what I have seen afterwards that majority of our patients were from Vapi and Ankleshwar. So they are having a very polluted air. So what we are telling it idiopathic. Then I started writing all the addresses and where they are living and everything, and then we realized that pollution itself is also causing oligoamniosis. Now we will see the results. So duration of prolongation. So after infusion, what we see, these are the prolongation of weeks. Okay? So from 2 weeks up to 15 weeks we are able to prolong the gestation. And you can also know as a gynecologist, even we can prolong the pregnancy up to 2 weeks also. That will increases the fetal weight and decreases the fetal morbidity and mortality. Neonatal morbidity and mortality after the delivery. So this is definitely very helpful. And here we can prolong the pregnancy up to 33, 34 weeks and here up to 36 weeks in 10 patients. And mode of delivery, 4 patients were delivered by vaginal route, 6 patients needed LSCS, and 1 had IUGR, 1 for patient's demand. Sorry for this. Here not here 11 patient vaginal route. 1 had IUGR, 1 patient demanded LSCS, 1 for precious pregnancy, 1 for breech presentation, and 2 were for fetal gestation. So in perinatal outcome, no baby had RDS septicemia. 1 baby needed NICU admission because baby was IUGR. What I told, that PIH patient or chronic hypertension patient. All other baby had birth weight more than 2 kg. Maternal outcome, no patient had septicemia or chorioamnionitis, because majority of our doctors are worried about, if I say amnioinfusion, even to the all fetal medicine people also, they always say, नहीं, क्या होगा, पूरा fluid डालेंगे, polyoamniotic हो जाएगा तो they are always worried about this, but they are doing so many procedures intrauterine, still they are not doing amnioinfusion. But in none of my patients had polyoamnionitis. 3 patients had PPROM, and there were no maternal death or complication. I think this patient is referred to me by Dr. Pratiji. This is her patient. I did amnioinfusion twice and sent her back for the normal vaginal. She was delivered normally, means by vaginal route. So this is that patient, and this patient, this boy is now doing MBBS in UK. In this patient, we did amnioinfusion 4 times, and she herself is a pediatrician and her husband is orthopedic surgeon. So I think their IQ is definitely normal even after doing 4 amnioinfusion. In follow-up, we have a follow-up of all babies varying from 1 year to 5 years. All milestones in this period were normal, and there was not a single case of mental retardation. So, in conclusion, I want to say all of you don't afraid for doing amnioinfusion. If you want to learn, I will come there at your place and show you. Okay? But do it because it is possible to successfully achieve good perinatal outcome in case of severe oligoamniosis in early pregnancy by single or repeated amnioinfusion. And just I want to add few points for amnioinfusion for normal vaginal delivery at full term, where FI is less than 5 cm, no severe IUGR, cervix must be favorable. If cervix is not favorable, then there is no use of doing amnioinfusion because we cannot induce that patient nicely. And willingness of the patient for the vaginal delivery. In this also we do trans-abdominal amnioinfusion under ultrasound guidance, and trans-cervical amnioinfusion we did in many cases having meconium stained liquor, thick meconium stained liquor, and the patient is going to deliver in 1 or 2 hours. Not it is very late or there is duration of delivery is still there. There is long time, then we don't do amnioinfusion from cervical road. But when the patient is going to deliver in 1 or 2 hours, then we can wash out that meconium to prevent meconium aspiration in these fetuses. So, for amnioinfusion for normal vaginal delivery, what I told that about the twins case, in that I did it in 1997, and then I did this amnioinfusion more than 1,000, and then I stopped counting them. So thank you for listening. Thank you so much, all dear friends.